say something? And I can only speak from personal experience, but our daughter was one of those high percentage who went into hospital through A&E, having had about 4 months of going to and from a GP. In the end, she said it's not worth it because they don't know the GP. And when she was in hospital, she eventually had a CT scan after about 5 days on the ward waiting and being bumped off the list. And then they found a mass. And then she was tested for Crohn's, for Hodgkin's and non-Hodgkin's lymphoma, and for TB because she'd been travelling abroad. And as a throwaway remark, the surgeon said it could be pancreatic cancer. And it was only when they did this vast operation that they found that it was pancreatic cancer. So I think and he was a pancreatic cancer specialist that we were fortunate to end up with. So, I mean, if he can't find it until he's actually in there looking at it, I think to expect GPs to be able to diagnose it, it's just very difficult. I mean, it's almost impossible for them, I would think, with these diverse symptoms. I mean, I would just say more access, quicker access to scans and a specialist diagnostician who could find the result.
The key is the quickest access to testing. And that's what we've talked about. I mean, the reporting of that testing will give you that there's something wrong, which will initiate your downstream. But getting access to the test in the first place in a timely way is quite important, isn't it?
Isn't there another question as to what test to ask for?
Yes.
My situation is that the carer died of pancreatic cancer earlier this year, and it was a 3-month wait to get a CT scan because the GP just did not know the pathway that was appropriate because it couldn't understand what the symptoms were potentially telling him.
I know. I mean, I'm not saying it's easy. I'm just saying that at the moment, some of the blocks that you have is access to the testing. So if you make a decision that you want something, and there will
help
be,
them to make
sure.
decision.
No, and we're not saying wanting to do this in splendid isolation, because that isn't going to happen. For a start, the commissioning of it isn't going to work unless there is a joined upness between those that commission, as in the CCGs in secondary care, and those that commission in primary care. So,
there's another. I mean, I became very involved in peer review for the last 10 years, and I very much applaud this move towards outcomes rather than processes. But I do remember that when the emphasis was on process, that there was one of the criteria, which was actually the communication between secondary and primary care on the appropriateness of referrals and the non-appropriateness. And that seems to have been lost now. And from a lot of what you've said has been, as I've understood it, general talk about cancer, whereas my understanding of pancreatic cancer is that it's very different in terms of the state of the art from other cancers that the NHS deals with, and needs very specific help to improve. And I don't get that from what you've said so far as being a priority.
And I'm not sure what you're asking me.
Sorry, I'm going around the houses. What I'm saying is that from my insight, okay, I've done 54 peer reviews, and I've become very involved through my friend in how pancreatic cancer is treated. And my perception is that pancreatic cancer is a very much neglected and very different case that needs specialist program to address, rather than a generalist, let's improve awareness, let's improve access to diagnostics. I think that there needs to be something that is specific to pancreatic cancer, which hopefully this all-party parliamentary inquiry will facilitate. Would you agree that?
I don't know what you want. I understand what you're saying, but
Yeah.
if we've got a system at the moment which means a patient has to present through to her GP, and either that through an emergency system, then within the hospital there's no doubt there is a concentration on the specifics of pancreatic cancer and the specialisation associated with it. That is happening and will continue to happen. Within primary care, there isn't. I can't figure out what the special thing is in primary care that you're after that needs to be done. So the answer is I am not answering your question, as it were. So you're right.
What I'm saying is that, look, I'm a breast cancer patient, a success story. My husband's testicular. Testicular has moved forward enormously in recognising symptoms and in no longer a dangerous disease. Similarly, breast cancer has fantastic improvement in survival rate. Pancreatic cancer seems to me decades behind, and to need specialist attention as it's such I think, a common cancer in things. And it's not getting it if you compare it with my experience, first-hand experience of breast and testicular cancer.
I think it's about prioritisation of recognising that actually it is in many respects a very special case because of the lack of progress that's been made, and acknowledging the need to prioritise it and to have some quite dedicated programs.
Picking up on that and being a little bit more specific about existing priorities, and this isn't about pathways or anything like that, it's a broad question. The strong impression we've had during the inquiry, which I think is not a surprise, is that particularly the Department of Health priorities have been formed by the concept of how many lives can be saved by early diagnosis, which add up to the 5,000 that will bring us up to.
I'm sorry, Alex, could you speak up? I can't.
Sorry. Clearly, that's. So I'm talking about a Department of Health priority, which is about saving 5,000 lives in relation to cancer through primarily early diagnosis campaigns and activities, and bringing therefore the lives saved up to the best benchmarks in Europe. And that clearly is a Department of Health priority, and those are the clear targets set out. So things where the money has gone, in terms of awareness-raising campaigns and the benchmarking work that you mentioned, has been very much focused on the numbers of lives that can be saved within that sort of broad concept. And we were told, which is right, I assume from the evidence, that would mean only 75 lives for pancreatic cancer could be saved. So we're very low on the list and very low down the priority in terms of that Department of Health money, which is an awful lot of money. Obviously we can influence other things, and there are other opportunities to make a difference, but in terms of where the priorities sit, I guess the frustration that we often hear from people like yourselves is that this is currently the 5th biggest cancer killer. And we understand from Cancer Research UK that potentially it will become the 4th, so it's going up the list in terms of going down the list in terms of survival rate, and potentially outstripping breast cancer, for instance. And we kind of do understand that it is a tough cancer. It's hard to find ways forward, and inevitably the Department of Health would look at the easiest opportunities because they want to make the biggest impact across lives generally in terms of cancer. However, it's quite a hard set of statistics to square in terms of where pancreatic cancer sits and should sit. So my question really is, given the changes that are happening your new role, the different priorities that are coming to the fore. Will anything change for pancreatic cancer, and what would your advice be in terms of how we do our best to make that happen over the next few years or so? Because this feels like it could be an opportunity for us, and we have to be very positive and very proactive about it. But it also feels previously that it hasn't been a priority, and there have been quite a few barriers there for us, for very perfectly good reason.
Yeah, thanks.
So the majority of the talk has been the bit that's not in the specialised. I was trying to follow where you were getting at. So the majority of the talk has been the big problem with pancreatic cancer is a difficult diagnosis. I think when you've had a scan or a lump into the system, the programme of work from the Department of Health, to be absolutely frank, makes no difference to the priority that NHS England will give pancreatic cancer in terms of commitment to developing the right service specifications, the right pathways of care, giving it the focus, by doing that through engaging in a wider way than has been done before.
Yeah.
So I think in terms of there is, I'm absolutely committed to making sure we equitably look at every cancer, and there isn't one that's more trendy than the other. Everyone has to have the right focus, and we must deliver the right treatments that we know are clinically effective in the most effective way, with the right specialisms looking after them, with the right experiences, so they're getting the right treatment. In terms of trying to deal with the pathway beforehand, that's where Sean has a difficult job to do, because he's trying to help make sure that patients get identified with this. It's a difficult cancer for easy identification, which is what you all know. So in terms of the point when you've got to the scan and you've got to the diagnosis, there is no reason why that the Department of Health priorities make no difference to the requirement that we will have as commissioners to focus on delivering appropriate service specifications to the best of our ability, engaging and helping research where appropriate, finding innovative technologies and innovative ways for treatment. Those are the key commitments that we need to take.
I'll add on to that, because I think we'll just bang both elements of this, because the strapline Lives Saved is a mechanism of engaging. It's not an easy one to measure. It was something that was created out of the gap in survival. So you can't measure that year on year. So it's a really hard one. And I don't like being there, because it makes me look like I don't know what I'm doing, but that's not the case. I've just inherited what I've got. But it is a rally call, and it's saying we can do better. And if you think about a consistent approach across the NHS to earlier diagnosis, whatever your condition is, means you're concentrating on wanting to get the services matched to you as early as possible, whatever your condition, whether it's your heart disease or whether it's your mental health, trying to get you to the right place early enough. And that's what the NHS generic message is, that we want to prioritise early diagnosis across our system. We'll benefit from that in cancer, despite the fact that because patients don't come through the GP surgery anywhere with a little badge on their head saying, I've got lung cancer, or I've got colorectal cancer. You come with a set of symptoms, and what you want is a system to proactively pull you through. So in one hand, I don't mind the strapline, because it is what is the call, if you like, for people to engage in that broadly, and we'll do okay out of it. It does not get you away from, I can't let go of each tumour site, because that's what you got me here for, to some extent, and that's right and proper. Equally, James and I will have the discussion that that's great for all the specialist cancers in terms of the service specifications, but I've got a big breast cancer community and a colorectal cancer community that don't have a service specification at the moment because they're not specialised, but I want one. So we've got to do that. So I'm not letting the system dictate where I want to try and keep banging the drum, and that's what my commitment is.
Can I ask a
Have to
question?
be quick.
Yes, I know we're running tight. It's to James, really, and one of the reasons we decided to run, I think, the inquiry when we did was because we were very mindful of the service specification development. And I suppose my question to you, quite simply, is, given that the improving outcome guidelines, for example, are quite old, whether or not they're dated would remain to be seen, but are you confident, I suppose, that what will come out of that process and the final set of service specifications will reflect the most up-to-date, progressive approach to treating pancreatic cancer patients?
So the key message is there won't be a final service specification.
Okay.
There will be an annual review of the
That's
service
right.
specification, which a group like this this is how you will influence the service. So we've been through.
I mean, we've got to go on forever.
We've been through.
APPG is for life.
We've been through national service frameworks.
Yes.
We've been through guidance documents. NHS England is now the sole commissioner nationally for pancreatic services. It must have a single national service specification. That service specification must be up to date with the most innovative treatments, with the cost effectiveness in there. It's a changing beast. Every year we expect it to change as new treatments show signs of efficacy, as we get better at engaging with patient groups of what they need from the service and not just what clinicians think they need from the service. So we intend to modify that service specification on an annual basis. If there may be a sea change in delivering a service, and we probably would want to give maybe 3 years' notice to the NHS system that pancreatic cancer needs a completely different way of delivering the service than we have now. You know, it needs to be done by one mega centre, right? Okay. That means so that we would then use a service specification notice of significant time frame to the NHS so that has come in. So it's got to be incremental. I would see the major importance of your output is to identify, particularly, as I say, in the post-diagnostic pathway, what elements might be considered as being appropriately included in a service specification. And we would welcome that advice from this group.
And would a nice quality standard...
Nicer updating. Or they're putting a request into NHS England to update
Yes.
pancreatic. So that...
Good.
Well, they're putting a request into, I think, if I understood it correctly, to take ownership of the improving outcomes guidance.
And we're going to say no.
Well, there's a step, and then I think it's for the NHS commissioning then to request NICE to do the update.
But we wouldn't wait for another version of an IOG to make a change to a service specification.
It complements it.
It's both. You know, so when the next IOG comes out, it would influence the service specification. But I think the output of this group should be able to influence the service specification as well.
On that positive note, because we're running a bit over time, I'm really grateful to you, Jen. Thank you so much. But I said, if something else occurs, then please, we're going to, and to everybody else, we're going to spend some time obviously getting a draft of what we want put together. So if anybody else has some thoughts or whatever, just file in the emails.
Can I just say very quickly, the vast majority of people that are diagnosed with pancreatic cancer are diagnosed in hospital, not by GPs, because they fail. I know it's very difficult, but they can't actually diagnose it. And then you go into hospital, and then it's part luck. Anybody that survives pancreatic cancer, it's purely by chance, because when you go there, you've already got a major problem. So everything needs to move very quickly, and it doesn't actually move very quickly. My wife was referred to hospital. She had an endoscopy, and then she was given a scan 4 weeks down the line. But she was actually admitted because her vomiting was increasing. So, you know, if you've got a major, and she had an endoscopy and they suspected a blockage, well, what does that mean? Can you wait 4 weeks for a scan? And that's the problem that most people have.
Well, that's why we've taken a lot of evidence about scans and heard today. We want to make certain recommendations.
But either
easier access to things
if the
like
doctor can't actually decide what's wrong with you. Maybe you need a scan straight away,
Well, that's-
especially when you're vomiting. But that's
Yeah.
not the case, is it?
But we've taken a lot of evidence about that, right? So we'll try and make some recommendations in terms of that.
But you can't really blame the GPs because it's very difficult for them to diagnose.
I'm not
But
blaming
when you go
GPs.
into hospital, it needs to move very quickly. And if somebody decides that you've got a blockage, you can't wait 4 weeks for a scan, you know, for somebody with pancreatic cancer.
Appreciate that.
Yeah.
Thank you. Listen, I'm going to have to give it out of this great place. But thank you, and thank you for the non-stop attendance by Secretary. We're grateful you've seen it through, and we hope you'll all be there in November. But I said if something occurs, please email through. Thank you.